Muscle energy techniques are highly effective for correcting joint misalignments or restricted mobility. These methods combine approaches to increase the flexibility of periarticular tissues with strategies to restore the proper length-tension relationship in the muscles controlling joint movement. Muscle energy techniques involve positioning the joint to optimize the contraction of a specific muscle or muscle group. During the technique, the patient performs an isometric contraction against resistance provided by the clinician. This causes the muscle to pull on its bony attachment, moving one bone relative to its articulating partner. Isometric contractions are typically held for 3 to 7 seconds, and the process is repeated 3 to 5 times before reassessing the joint. For joint mobilization, moderate contractions are preferred over maximal efforts, as excessive force can stiffen or freeze the joint. These techniques are particularly valuable as alternatives to more forceful manipulative procedures. To fully grasp the principles and applications of muscle energy and functional techniques, it is essential to understand Core's concept of segmental facilitation and the work of Patterson and Sherrington on spinal reflexes. According to Core, excessive gamma motor neuron activity to the muscle spindle reduces the amount of external stretch needed to activate the primary annulospiral endings. This, in turn, reflexively fires the extrafusal muscle fibers via alpha motor neurons. These exaggerated spindle responses are triggered by movements that lengthen the facilitated muscle, creating a restrictive spinal fault. The goal of muscle energy and functional techniques is to restore normal neurophysiological function to the affected segment. One of the key mechanisms involved in muscle energy techniques is the Golgi tendon organ, which plays a crucial role in regulating muscle tone and preventing excessive force on tendons during muscular contractions. When the tension on a muscle increases significantly, the Golgi tendon organ initiates a lengthening reaction, resulting in sudden relaxation of the muscle, thus protecting the tendon from potential injury. This reflex is distinct from the stretch reflex mediated by muscle spindles, as the Golgi tendon organs respond to both active and passive muscle contractions. The application of muscle energy techniques involves isometric contractions followed by postisometric relaxation, which capitalizes on the inhibitory feedback from the Golgi tendon organs. This process allows for a temporary reduction in muscle tone and facilitates increased range of motion in shortened or restricted muscles. Research has shown that muscle energy techniques can improve local circulation, enhance lymphatic drainage, and positively influence both static and dynamic postures due to its effects on proprioceptive pathways. In the context of somatic dysfunction, which can adversely affect a range of physiological processes, muscle energy techniques serves as an effective therapeutic approach to restore biomechanics and alleviate pain associated with various musculoskeletal conditions. The technique also engages mechanisms such as the crossed extensor reflex, whereby voluntary contractions of muscles inhibit the contralateral muscle while activating its antagonist, further illustrating the intricate neural pathways involved. The underlying mechanism of muscle energy techniques involves a controlled contraction of the patient's muscles against a counterforce provided by the therapist. By adjusting the direction and intensity of the applied force, therapists can either overcome or match the patient's muscular efforts, guiding the healing process while minimizing discomfort. The muscle spindle is a sensory receptor located within skeletal muscles that detects changes in muscle length and the rate of length change or velocity. It plays a critical role in proprioception and the regulation of muscle tone. The muscle spindle includes 1. Intrafusal muscle fibers, which are specialized muscle fibers within the spindle. 2. Sensory endings, which are A. Primary annulospiral endings that respond to both the rate of change and the absolute length of the muscle. The rate of change means dynamic response, and the absolute length means static response. B. Secondary flower spray endings that primarily respond to the absolute length of the muscle. 3. Motor endings or gamma motor neurons. Innervate the intrafusal muscle fibers and control their sensitivity. The gamma motor neurons are part of the efferent motor system that innervates the intrafusal fibers of the muscle spindle. Their primary role is to regulate the sensitivity of the muscle spindle to stretch. Gamma motor neurons cause the intrafusal fibers to contract, which stretches the central or sensory region of the spindle. This maintains the spindle's sensitivity to stretch even when the extrafusal muscle fibers contract or relax. There are two types of gamma motor neurons. A. Dynamic gamma motor neurons that increase the sensitivity of the primary annulospiral endings to the rate of stretch or dynamic response. B. Static gamma motor neurons increase the sensitivity of both primary and secondary endings to the absolute length of the muscle or static response. When gamma motor neuron activity is excessive, the intrafusal fibers are overstimulated, leading to increased tension in the muscle spindle. This has several consequences. 1. Increased sensitivity of the muscle spindle due to the increased sensitivity of the primary annulospiral endings. As a result, even a small amount of external stretch can activate these sensory endings, leading to a heightened response. 2. Reduced threshold for stretch reflex. The stretch reflex or myotatic reflex is triggered when the muscle spindle detects stretch. Excessive gamma activity lowers the threshold for this reflex, making it easier to activate. This can lead to hyperactive reflexes and increased muscle tone. 3. Muscle spasm and pain. Excessive gamma activity can cause the muscle to remain in a state of contraction or spasm, as the spindle continuously signals the central nervous system to maintain muscle tension. This can contribute to pain and restricted movement. Functional techniques, developed by osteopathic physician Harold Hoover, aim to reduce the heightened spindle response in facilitated segmental muscles, thereby restoring normal joint mobility. Similar to combined movements and strain-counterstrain, functional techniques involve finding the most pain-free starting position and applying gentle, repetitive motions or sustained holds. The objective is to achieve an antalgic, pain-relieving position, reducing input from overactive nociceptors. Strain-counterstrain gained popularity in the 1970s and continues to grow in use among practitioners. Developed by osteopathic physician Lawrence Jones. Jones defines strain-counterstrain in two ways. 1. Relieving spinal or joint pain by passively positioning the joint in its most comfortable position. 2. Reducing pain by decreasing inappropriate proprioceptor activity. This is achieved by significantly shortening the muscle containing the malfunctioning spindle while applying mild strain to its antagonist. The technique is based on the concept that the position of injury places some muscles in a shortened state and others in a lengthened state. As Core's neurological model explains, excessive gamma motor neuron activity to the intrafusal fibers of shortened muscles increases tension in the muscle spindle. This excites the central nervous system, stimulates alpha motor neurons, and maintains contraction in the extrafusal fibers. The technique is thought to reset dysfunctional muscle spindle activity by placing the muscle in a shortened, relaxed position. This reduces the afferent input from the muscle spindles to the central nervous system, thereby decreasing muscle tone and spasm. Two critical aspects of this procedure are: 1. Using the tender point as a guide, the practitioner positions the joint to reduce aberrant afferent signals and return the muscle to a state of easy neutral. 2. Holding this position for 90 seconds, the time required for proprioceptive firing to decrease in frequency and amplitude before slowly returning the joint to neutral. Additionally, strain-counterstrain may influence the autonomic nervous system, particularly the parasympathetic nervous system, promoting relaxation and reducing pain. The gentle, sustained positioning in strain-counterstrain may activate the parasympathetic response, counteracting the sympathetic response often associated with pain and muscle spasm. Indications for strain-counterstrain. Strain-counterstrain is particularly effective for conditions involving acute pain, muscle spasm, and tender points. Common indications include acute musculoskeletal pain, muscle strains or sprains, cervical or lumbar spine pain, whiplash-associated disorders, myofascial pain like trigger points or tender points in muscles, myofascial pain syndrome, joint dysfunction like facet, joint irritation or hypomobility, sacroiliac joint dysfunction, postural pain like pain related to poor posture or repetitive strain, referred pain like pain referred from other structures, e.g., shoulder, jaw, or thoracic spine, post-surgical or post-trauma pain, pain and muscle guarding following surgery or injury. Contraindications for strain-counterstrain. While strain-counterstrain is generally safe, there are certain situations where it should be avoided or used with caution. Absolute contraindications are: avoid strain-counterstrain in areas of unstable fractures or dislocations. Avoid in cases of acute infection or inflammation like septic arthritis. With severe osteoporosis, there is risk of fracture with positioning. Avoid over areas of known or suspected cancer. Avoid in cases of arterial insufficiency or deep vein thrombosis. Relative contraindications: hyperalgesia or allodynia, as patients with heightened pain sensitivity may not tolerate positioning. Patients with severe pain may not be able to find a comfortable position. Use caution in patients with peripheral neuropathy or central nervous system disorders. Use caution when positioning pregnant patients, especially in the later stages.